Hello everyone, good afternoon. First of all, I want to thank the chairman, Dr. Rishma Pai, for her introduction, but also for her chairing this program over the last 2 days. She has done a marvelous job, and congratulations for leading this educational programs. I also want to thank the organizers, Merck Fertility Academy, and the team headed by Dr. Agarw and his associates, Jessica, Elise, Revati, who have done a marvelous job over the last several months, coordinating with me and maybe with other speakers in helping us create a very wonderful program and guiding us step by step to make sure that we comply with the guidelines of Merck. Thank you. Also, the local coordinator, Yolanda, for her help in arranging all the facilities here. Without her, I don't think we'll be able to find where this room is. So thank you very much. And I want to thank many of my fellow speakers who are really distinguished speakers from so many different parts of the world. I have been very lucky to be able to hear several of them, although I don't know much about IVF myself, but I try to do some of their post and pre questions, and I think I failed miserably. So I think they have done a great job, and I congratulate them for this their participation here. I also want to thank all the respected guests here who have come here to attend and listen to us. Thank you very much for coming and participating in this program. So I don't have any thing to disclose except for you, what you see. I have really appreciate the sponsorship from Merck for allowing me to come here. So in today's program, in my talk, I'm going to cover several of the things that you see here, and hopefully provide you an idea of some of the advances that are happening at the diagnostic area. And then my colleague and the next speaker, Dr. Ivan, is going to take over and talk about many of the treatments for patients with male infertility. So my mandate or my talk is going to cover not all, but some key areas in terms of the diagnostics advances in male infertility. So we are hearing, and I think Dr. Shesh alluded to it in her panel discussion about the changes that we are seeing in many parts of the world where the population growth is really maturing or are declining. And there is a lot of concern about that, which is not always related to an explosion of infertility per se, but I think it is a host of other conditions. Some of them are societal changes, where the couples just don't want to have more than one child, but there are other lifestyle changes and many practices where couples are not, or men and women are not marrying, they are living together, and so there are all kinds of things that we are seeing. We had just a recent announcement from ASRM that they have broadened the guidelines for infertility by including the same-sex couple as part of infertility, and also trans men and women as those who are considered as part of infertility group of men and women who are patients now. So I believe the definition of infertility is changing, but also the dynamics of population in different parts of the world are changing. But what is important is that whatever things are happening, there is definitely a decline in the semen quality in around the world. And there are so many studies that we see that have come out, and I'm going to touch upon few of them. But also I wanted to show you this thing from, if you have heard of Erin Brockovich and Julia Roberts in that very famous movie, which was based on this character Erin Brockovich. They came out with a news item recently, and I was contacted to actually by the reporter to comment on it. But more importantly, I think if you look at it, they are predicting almost a 60% decline in semen quality in the last 50, 60 years. And this is not something which is just made up. I think it is based on very nice meta-analysis that have been published. And this one came out from Levin from Israel, published in Human Reproduction about 6 years ago, which shows that there is a significant decline in all the important semen parameters, whether it is count, motility, morphology, and it is in many parts of the world. Then the same group of authors showed that the decline is actually accelerating in a new meta-analysis. And if you look at the results here, over the years, in the last several years, the decline is getting even accelerated with more data that they have created. And this data, which includes the data from some other continent which were not included earlier, such as South and Central America, Africa, and Asia, which were missed in the earlier study, seems to basically confirm their original findings and show that there is a rapid decline which is happening, and certainly it is something of great concern to everyone. And what are the key causes for the rise in male infertility? Of course, many of these, as you see here, are known to you, so there is nothing very new here. I mean, these are traditional causes that are there, but on the right, if you look at these causes, I think these are things that we are trying to understand more. Paternal age, late marriages, decline in semen quality, all of these things. There is an explosion of sexually transmitted diseases, both in reproductive age, male and female, and as well as the environmental causes, which is something which is really alarming. The air we breathe, the water we drink, the food we eat, everything is contaminated with these chemicals called phthalates, or they are called forever chemicals. And they are present in very, very small quantities, but we are absorbing, we are taking it all the time. And they are harmful. They may not express themselves in the first generation, but they may express in the subsequent, in their offspring. And this is something that we are learning more with the epigenetic studies that are going on. Lifestyle factors and so many things. Stress, not only because of the pandemic, but stress in general has increased. It has skyrocketed. In some parts, in some countries, the physicians are not able to cope up. I mean, they are really short of physicians or caregivers who are responsible for psychological health. That field has just ballooned, and the number of people seeking help is just skyrocketed. Everyone has a problem, whether they are young or old. I mean, it's just something which is going like crazy there. But and I was talking about the endocrine disrupting chemicals which are coming from all over. I mean, there are chemicals like phthalates and bisphenol and so many. And we understand now they are really causing a variety of effects. I'm only talking about the male, but of course they are something that is happening on the female side. But what you see is that they have a variety of mechanisms by which they are acting, and they are causing changes that we are seeing in terms of oxidative stress, changes in testicular histology, increased DNA damage. These are based on studies that we have seen and certainly contributing to male infertility. Furthermore, paternal age is also, unlike in the female where there is a very definitive kind of cutoff of the age of 35, in the male, again, in large number of meta-analysis and studies that have been published, it has been shown that over the age of 40, 45, there is a significant decline in semen parameters. There is a higher amount of sperm DNA fragmentation and an increase in genetic and epigenetic conditions, changes which are happening. And these are contributing again to various kinds of defects which affect the ART results in couples. Furthermore, radiation and its effects, I think for those who, I mean, all of us use cell phones, so I don't think anybody is really beyond these effects. These are really coming through the electromagnetic waves which are generated by cell phone towers, wireless, laptop, and there is a great deal of studies going on. We were the one who published many years ago the effects that showed that there is a significant decrease. Of course, this was an observational study. It's very hard to conduct hardcore studies which can show cause and effect. It's unethical to conduct such studies, but whatever evidence that is there, which is supported by animal studies data, seems to indicate that there are various mechanisms which they have been hypothesized that show these electromagnetic waves make their way to the testicular tissue and cause a variety of changes that are expressed in terms of poor semen quality and higher oxidative stress and sperm DNA fragmentation. The global incidence of male infertility is really shrouded in secrecy. I think everything is focused on the woman, on the female, and all the literature, all the science, all the articles, if you look through in PubMed or Scopus or wherever, are just talking about the data on the female. Nobody wants to talk about the male, although we know that half of the problems are due to the male factor. So it was one of the things that we wanted to do, and we conducted a study many years ago, about 7, 8 years ago, and using epidemiologists, using statistical modeling, using all the data which was there for the female, we were able to predict or model that almost 100 million of the cases of people who are infertile are due to male factor. So the data from the WHO that you see here is about 200 million, but this is almost 25-year-old data. So I suspect that the incidence of infertility in general perhaps could be as much as 300 to 400 million around the world. But if you look at, if you consider that 30% is due to the pure male factor and the rest 20% have a contributory male and female, then this data becomes really huge for male factor. And compounded to that is the fact that only half of the patients with male factor have a defined cause which really could be treated either medically, surgically, or through lifestyle. But in other, we have no idea what is going on. And this is what we call as idiopathic. I mean, I think, and I tell that idiopathic means that we are not smart enough to really tell what is going on in these men. And we put a very cute word called idiopathic. You have idiopathic infertility. So the patient goes and tells his wife, oh, I am having idiopathic infertility. And it's like a great thing. But the thing is that's really sad. Even in this day and age when we are, going to send the rockets to moon and to Mars, we have half of the patients with male factor infertility where we have no idea. And I think the reason for it is that we have really not invested into the diagnosis of male infertility. So I want to come to the issue. This was just a preamble to what my talk is. So over the years, World Health Organization was the one who has spent a lot of time in terms of creating these guidelines for the examination of human semen. And they came up with these consensus documents made up by experts. Since 1980, it's been a large number of years, almost 40, 50 years. And the last edition is called sixth edition. And these documents contain a variety of SOP or standard operating protocol for the laboratories to follow to conduct various tests and procedures. But they are highly technical in nature. It's very difficult for most people to understand, especially for the clinicians, to really get a handle as to what they are really supposed to do, because they don't tell when to order this test, what this test means, when it is abnormal, what are you supposed to do. So even though these try to provide a standardized information, but the information is too complicated for most clinicians. We have basic test, which is a routine semen examination, and that hasn't changed. I mean, if you look back at the invention of microscope and the discovery of human sperm in 1677 by Leeuwenhoek, Anthony van Leeuwenhoek, and since then, I think there hasn't been a whole lot of change in how a semen analysis is conducted. So you can imagine we have really come a long way, but the process of conducting a semen analysis hasn't changed. We're still doing the same thing. It's completely subjective. It's a useless test. Most of the people really cannot do it, although they think that they are doing it, but 95% of the test results are wrong. So, sorry, back. So there are a lot of advanced tests that have been developed which are looking at the functional properties of the sperm, such as its binding to the zona in the natural fertilization condition, chromatin condensation, acrosome reaction, and sperm ulama binding. So many of the properties which prepare the sperm to fertilize an egg are the focus of advanced tests. And many of them on the left side of the figure you can see. These are not all, but these are some of the tests that are part of those advanced functional tests. Some are molecular, some are biochemical in nature, but they are definitely not something that you can do under the microscope like a semen analysis. So semen analysis is highly inaccurate, it's simple, it is deceiving. I think people feel that anybody and everybody can do a semen analysis, but that's not the case. Yes, you can, but the results are basically garbage in, garbage out, so you get really nothing. And actually, there's a lot of downside to it. There's a lot of confusion that leads to inaccurate results, and certainly it confuses the clinicians in terms of their management for these patients. So there have been advances in andrology. These are just few things, but there are so many other things that have happened. I don't have the time to cover all of that. But home sperm testing, probably it's nothing new. It has been there for many years now. And essentially, it's a simple kind of test that allow the couple or the male partner to know whether they have an abnormality or not. Then they can seek a professional qualified physician for their care. But what is interesting, which has happened in the last 5 years or more, at least in the United States, is the onslaught of remote testing for both male and female partner. Many of the internet-based companies have started business where the couples can basically seek testing, and they can ship the samples, and then basically those samples can come from any part of the United States to the company. They go to certain labs, and then they get the results next day. So these results are much better in terms of the quality of the results. They are very much similar to professional clinical laboratories, and that model has become quite common now in the United States. So in terms of the advances that are happening. But more important is the advent of AI or artificial intelligence in semen analysis, and they are pretty much entering into all areas of reproductive medicine. Certainly, there is a lot more on the ART side than on the andrology, but nevertheless, andrology is not untouched. AI is getting into it, and certainly machine learning, which includes 3-4 different types of databases, such as one is for training. For example, for semen analysis, if you have normal spermic samples, you have hundreds or thousands of samples results. You have the programmer enter those results to teach the machine certain attributes that these sperm are normal or abnormal. And then there is a validation data set and then a prediction model, which will allow the machine to be able to predict with accuracy 95, 98%, 100%, whatever. And then the next is once the machine gets enough confidence, then the deep learning, that it starts doing it all by itself with higher level of precision. So this is called deep learning, which does not involve much of human intervention. The limitations of current computer-assisted semen analyzers are they are very big, they are very expensive, they require human intervention, and they are not very accurate. So the newer machines that have come up in the market over the last 5-6 years are really making a huge difference. There are several machines which have been now available in the market, and these are using AI, and you will see that the results can be obtained within few minutes time, and they are highly accurate, highly precise. It can do all the things that a human does. In one of the device that we have tested, clinically tested and published, you can see our paper on the PubMed. I will not be allowing talking about the actual brand or anything here, but certainly I think we had very good results. And there are other companies which are also coming into the market or already have products which are using AI in the so why do we need advanced sperm test? I think we need advanced sperm test because there is a lot of variability in the results of semen. There is a great deal of overlap between the results of fertile and infertile or male factor infertile. So you don't know whether that result is really of patient. I mean, is it really abnormal or normal? Because of the overlap, the results are very difficult to discern. So there are various advanced sperm function tests. Many of them came before the advent of ICSI, and then scenario changed, so things are now really changing rapidly. Many other tests have come in, many more, especially on the epigenetic side, are really under development. They are trying to work on those tests to make it easier for routine diagnostic purposes. They are not there yet, but I think there is a lot of work going on behind the scene. I want to talk about oxidative stress. Oxidative stress is really an imbalance between oxidant and antioxidant, and it's a status which is implicated in almost 100 human diseases, whether it is heart disease, whether it is any kind of cancer. Everywhere oxidative stress is implicated. And the concept of oxidative stress is very well known. It has been implicated in male fertility or sperm dysfunction for over 50, 60 years, but we still have a long way to go in terms of really using this knowledge for therapeutic purposes. So if you look at the diagram, you can see the triggers for oxidative stress are either endogenous or they are exogenous, or they can be environmental or health reason which result in this imbalance which causes the oxidative stress. And the oxidative stress can be defined here, which is a balance between reactive oxygen species and antioxidants. But it can be physiological or pathological. So physiological, you really need very small quantities of these free radicals, which collectively are called reactive oxygen species, for very important functions leading to fertilization. So we don't know what exactly is physiological, but we know from the literature, from the studies and experiments that have been done, that we need physiological, and under pathological condition, they become harmful. So we have oxidative stress, and then we have reductive stress. So we were very interested since the concept of oxidative stress has been there, but there hasn't been any diagnostic modality available. Certainly without the easy and simple diagnostic, these type concepts cannot be actually used for therapeutic purposes by the clinicians. So our goal was to really see what is physiological and what is pathological levels of these oxidative stress. So we wanted to look at that by a variety of laboratory experiments that we conducted. And I will summarize these results in just few lines. The effect on semen parameters, although are comparable between oxidative and reductive stress, but the management of both of these conditions are very different. And also we were able to actually establish the actual range of oxidative and reductive stress, which has never been done in the literature. People only know theoretically that there is oxidative stress, there is the physiological level, but nobody was able to establish. So through exogenous experiments, we were able to establish what is the exact dose or actual level of when it is pathological or physiological. And we were able to also develop a term called male oxidative stress infertility. The difference between the idiopathic infertility, as you will hear also in our subsequent talk, it means abnormal semen quality, but MOSI, or this condition which we defined as MOSI, is abnormal semen quality with high oxidative stress, no female factor, and no other identifiable cause. So the indications for oxidative stress are idiopathic infertility, abnormal semen quality, leukocytospermia with the definition of WHO, no anatomical, endocrine, or genetic causes, and no female factor. And there are a variety of tests for oxidative stress, but most of them are useless because they are most suitable more for research, and they are very cumbersome, difficult, and they are not reproducible. So there was a need, if we have this concept of oxidative stress, we need a test. So we developed this test called oxidation reduction potential, which is a measure of oxidative stress because it really provides a snapshot of oxidant and antioxidant in the same semen sample. We published our article with the complete protocol in several years ago, and we were able to demonstrate that the ORP can be measured reproducibly in both fresh and frozen sample, which is a difficulty for many types of analysis on semen because you have to do most of the test on the fresh semen. The tests are not reliable after 1 or 2 hours of semen production. Also, it showed that ORP is very reliable, very stable. We conducted a multi-center study with 9 institutions and looking at more than 2,000 patients, and we were able to demonstrate or establish the cutoff value of ORP so that it can be used for routine purposes. In terms of the clinical guideline for MOSI, it should be suspected in infertile men with abnormal semen characteristics and oxidative stress. Many of these men were previously classified simply as idiopathic, and they were treated empirically with a variety of agents which really have no scientific basis, no randomized control trial, or any kind of professional society guideline backup. So they were done. I think some of them become successful. It's a hit and miss. So these men should be offered testing for oxidative stress. Now let's touch upon another very important topic, which is the sperm DNA damage. Sperm DNA damage is really an area of great interest over the years. Over the last 10, 15 years, there is a lot of research going on, a lot of clinical trial, a lot of guidelines that are coming out. So I thought this would be important for all of you to kind of get to hear. And we have a lot more information on this than any other type of test for sperm for male infertility. So the mechanism of sperm DNA damage is really multifactorial. We have both the testicular causes and intrinsic causes, such as abortive apoptosis and defective maturation, but also external factors such as testicular cause, and which includes oxidative stress. So oxidative stress is not the only cause for sperm DNA damage. Some people ask me, can I do the oxidative stress, and is that going to be enough for looking at the sperm DNA damage. I don't think, because if the pathologies are different, you may get some correlation, but it really is not like a surrogate test for one or other. And the risk factor, as you can see, are advanced paternal age, diet and lifestyle, etc. And the clinical implications are leading to impaired reproductive outcome and increased risk of birth defect. And there are various types of sperm DNA damage. We know more about the sperm DNA fragmentation as opposed to many others. Of course, Y chromosome microdeletion is most common in azoospermic patient, but other types of DNA damage like mitochondrial DNA or telomere shortening or epigenetic abnormalities haven't really panned out because we don't have any diagnostic means to evaluate them. I'm sure that they are there, but we really are not ready yet in terms of trying to figure out how much that plays a role. Indications, this is important. Unexplained male infertility, normal parameters and no identifiable underlying cause. Idiopathic, which is abnormal semen quality, and recurrent pregnancy loss, risk factor of advanced male age, and some of the lifestyle issues, chemicals and radiation, as well as ART planning and sperm cryopreservation. So these are some of the causes. There are several types of tests that have been defined. Should be finishing in a few minutes. In the WHO 6th edition, they have not really identified a single test. They are given a bunch of tests. There are 4 different tests that have been provided without any kind of threshold value. So whether it is sperm chromatin structure assay, SCSA, tunnel, SCD, which is sperm chromatin dispersion test, or COMET. So all of these tests are described in the WHO, and they all have different principles. They have different advantages and disadvantages. So the clinics really have to take the burden of understanding these tests, doing their own clinical trial to establish the cutoff value before implementing these tests in their own group of patients. The most evidence of these among all these tests is on tunnel. Tunnel has the most literature, but that doesn't mean that that is the only test to be done. So these are some of the tests. I'm not going to go into any of that detail. I'll just leave you with these tests. These are the ones that have been described in the WHO 6, but certainly WHO does not make a recommendation. It doesn't tell which patient you should test or what is the cutoff or the threshold value. None of that is available in WHO 6. So these are 3 different meta-analyses, including thousands of patients. What I wanted to convey from this slide is the fact that irrespective of the type of methodology for sperm DNA fragmentation that has been used and included in these meta-analysis by different investigators, which looked at the effect of sperm DNA damage on IVF and ICSI outcome, the main conclusion is higher the SDF level, lower the clinical pregnancy by IVF and ICSI. So this isn't based on one single study, based on very large number of studies, of course. How to reduce the sperm DNA fragmentation? There are many different techniques, many strategies that can be used. Some are really non-invasive, easy, simple, doesn't cost a whole lot of money, while others such as use of testicular sperm in certain cases is more invasive. So there are many ways by which you can reduce the incidence of proportion of sperm DNA fragmentation in the samples which are used for ICSI, but you can never completely eradicate or remove every single sperm with its damage. So this is a management of how infertile men with elevated SDF can be managed. Now let me come to my last slide. So idiopathic male infertility is a broad diagnosis that can be a really emotional burden and a financial strain for couples because we really are not able to provide them the correct treatment, and a lot of it is just a hit and miss. AI-based semen analyzers can offer fast, easy, and reproducible results. I think this is really a high time that many of you try those, do your testing to see if those type of devices will be useful in your clinics. The doctors and patients should not ignore oxidative stress, because we found almost 80% of patients with idiopathic do have high levels of oxidative stress. So this is a condition. Sperm DNA fragmentation is an important marker of sperm function, and it should be included in the evaluation of male infertility in selected patients along with semen analysis. Sperm preparation techniques and advanced sperm selection methods such as IMSI, MAX, etc. can be used to select a healthy sperm for ART procedure. So there are a variety of laboratory-based procedures that are already there, and many of you probably are using it, which can allow you to select healthier sperm, but that doesn't mean that you will always be successful. You will have a higher chance of selecting healthier sperm. So with that, I take leave. Thank you very much from Cleveland, Ohio.